I welcome you all to the webinar on diagnosis of urinary tract infections. Today, um, as you all know, urinary tract infection is a common problem in diabetics as well as in normal human beings also, particularly in ladies, and which causes morbidity and a lot of problems like septicemia and failures of upper urinary tract infections, pyelonephritis and all, which will be causing a lot of problem to the patients. Besides this, urinary tract infection in pregnant women can cause many complications like premature labor, infection to the babies, and including perinatal death also. So, urinary tract is such an infection which has to be diagnosed early, and a treatment is to be instituted immediately. So when it comes to this point, we have Dr. Kishore, who is an eminent microbiologist working at Vijaya Diagnostic Center, Tirupati branch, as a part-time microbiologist. Today, he'll be giving, he will be delivering this webinar a few points about the diagnosis of urinary tract infections. Dr. Kishore
Hi,
is
sir.
working. Dr. Kishore is working as a professor at Apollo Institute of Medical Sciences and Research, Chittoor. He has done his undergraduation from Sri Venkateswara Medical College, Tirupati, as well as his post-graduation also from Sri Venkateswara Medical College, Tirupati. Later on, he went on to work as assistant professor at Shantiram Medical College, Nandyal, and he had a good experience over there. After that, he changed his medical college and he worked at another few more private medical colleges. And later on, he shifted over to Apollo Institute of Medical Sciences as professor, and he is continuing over there. Now, he has vast teaching experience of 17 long years teaching his undergraduate and postgraduate students. He has been a guide for PhD students also, and there are around 3 students who are presently working with him to get their PhDs. He is also a member of IAMM and IATP, a life member, as well as he is the treasurer of IAMM TAPC, that is Telangana and Andhra combined pathology and microbiological institute. Sorry, pathology and microbiology, Telangana and Andhra combined chapter of state. So he is a life member as well as he is the treasurer in that. He has total 8 publications to his credit, and he has a good experience about diagnosis, treatment, and he will also discuss a few points about the treatment aspects of urinary tract infections. Today, he'll be sharing his knowledge about urinary tract infections with us. Now, I invite Dr. Kishore sir to take over and explain this urinary tract infections with the help of a PPT. Thank you. Dr. Kishore, please.
Thank you. Thank you very much, sir. Am I audible?
Yes, very clear.
Yes, sir. So thank you very much for your brief introduction, sir. And I thank the Vijaya Diagnostic Center for giving me this opportunity to come forward to present a few briefing about the presentation regarding diagnosis of urinary tract infections. Thank you. Thank you very much. I'll be sharing the PPT. Are you able to see, sir?
Yes, yes, Dr. Kishore.
Is it okay now? Bigger screen.
Yes, sir. Very clear.
Yeah. Diagnosis of urinary tract infections. So, before going to exactly know what all the various methods of diagnosis of urinary tract infections, I just wanted to give a brief info what exactly is urinary tract infections. If you just check to define what a urinary tract infection is, so it's a disease caused by microbial invasion of urinary tract that extends. Can you see the PPT?
Yes, sir. We can see.
To see that.
Yes, sir, we can see.
Yeah, okay. It's a disease caused by microbial invasion of the urinary tract that extends from the renal cortex of the kidney to the urethral meatus. So it is the distance between the renal cortex to the urethral meatus. Mainly leads to cause morbidity and also healthcare expenditures in persons of all ages. So the reason why it is very much important is, so not only the morbidity, but also it causes healthcare expenditure, especially mainly due to the healthcare, not only the community associated infections, but also the hospital acquired infections. So these urinary tract infections can be classified broadly into two types. One as a lower urinary tract infection and one as an upper urinary tract infection, depending upon the site that is being involved. It's an anatomical site that is being involved. And also you can classify them based upon the source of infection, that is either it as a healthcare associated infection, mainly in the hospitals, which you call them as COTI. COTI is nothing but catheter associated urinary tract infections, and also community acquired infections, urinary tract infections, which we routinely commonly see daily patients on an outpatient basis. So if you compare to see what is a lower urinary tract infection and what an upper urinary tract infection is, the site that is involved in lower urinary tract infection is urethra and bladder, only urethra and bladder. Whereas the upper urinary tract infection, you just see that the infection may be involving the ureter and also the kidney. The symptoms generally that you see in lower urinary tract infection are local manifestations where you see difficulty in passing urine, dysuria, and urgency and also frequency of urination. Whereas the upper urinary tract infections, mainly involving the ureter, you see local and systemic manifestations like fever, vomiting, and abdominal pain. And the route of spread in lower urinary tract infection is ascending route, whereas in upper urinary tract infection is both ascending and descending routes, whereas the ascending route is more common. In the occurrence, if you see, the lower urinary tract infections are more common, whereas the upper urinary tract infections are less common. So by this, you can compare the urinary tract infections as a lower and upper urinary tract infections based mainly on the site that is being involved. And before going to know what exactly is the diagnosis, we need to know about its epidemiology and the agents that are mainly causing the infection. Let us see the epidemiology. Apart from the respiratory tract infections, which are more commonly seen in the community, urinary tract infections are the second most common infections other than the respiratory tract infections. If you look into hospital-acquired infections, urinary tract infections are the most common. Approximately about 35% of the total healthcare associated infections or hospital-acquired infections are mainly due to the urinary tract infections that we talked about regarding COTI, that is catheter associated infections. And the prevalence rate of urinary tract infections in the entire lifespan, if you take approximately 10% of the humans develop urinary tract infections in their life, approximately if you take the age of 75 as the cutoff age. Approximately 10% of the humans will develop the urinary tract infection in any part of their life. And for the causes of the urinary tract infections, there will be certain predisposing factors that can lead to prevalence or increase in the rate of the urinary tract infections. Mainly, one is gender, higher prevalence in case of females, and it is due to short urethra and close proximity of urethral meatus to anus. And age, increased incidence with age. There will be an increased incidence of urinary tract infections with age. And if you look into the first year of life, during the first year of the life, prevalence is same both in males and females, but incidence rate is more in case of males. That is in the first year of life, it is more in case of males. Whereas in females, it increases after the first year of life. 5 to 17 years, incidence of bacteriuria is about 1 to 3%. In adult life, it increases to around 10 to 20%, whereas a reinfection is common in case of females, where you see them at the age of, that is mainly the reproductive age, where we call it as 20 to 40 years of age. Pregnancy, anatomical and hormonal changes in pregnancy is one of the predisposing factors, where you see asymptomatic bacteriuria, which is commonly seen in case of pregnancy. And apart from these, there are structural abnormalities where you see structural obstruction, and also functional abnormalities in the urinary tract, where you see mainly a neurogenic bladder due to spinal cord injury or multiple sclerosis. So the structural abnormalities might be urethral stricture, renal and ureteric stones, and even prostate enlargement in the aged people, tumors sometimes, and renal transplants also. And apart from the human factors, predisposing factors, there are even certain factors like bacterial factors also. Like if you see, some bacteria have pili, which can adhere to the uroepithelium and cause virulence, leading to urinary tract infections. And vesicourethral reflux is one factor where it allows the urine from bladder up into the ureters and sometimes into the renal pelvis, which can lead to infection of the ureter and also the cortex of the kidney. Genetic factors, genetically determined receptors, which can help in the bacterial attachment, can also play a role in causing urinary tract infections. And if you look into the organisms that mainly predispose causing this urinary tract infections, mainly Escherichia coli, which is uropathogenic Escherichia coli, commonest cause 70% of all forms of urinary tract infections, especially the community acquired and nosocomial urinary tract infections, and upper and lower urinary tract infections also. Other endogenous flora can also cause, like which are being as flora at other sites in the human body, like gram-negative bacilli, like Klebsiella, Proteus, and even sometimes Enterococci also. Hospital-acquired urinary tract infections mainly being seen with, again, Enterobacteriaceae family, like Escherichia, Klebsiella, Proteus. Apart from that, certain gram-positive bacteria like Staphylococci, and certain non-lactose fermenting bacteria like Pseudomonas, Acinetobacter, all this also can cause what you call the urinary tract infection as a part of hospital-acquired infection. So in total, if you tabulate and see, there are various bacterial agents that can cause, even the fungal, parasitic agents, even the viruses that can cause the urinary tract infections. Predominantly, we see mainly the bacterial, and rarely, sometimes we see the fungal, especially the Candida albicans also to cause. And bacterial agents, gram-negative bacilli are the more predominantly seen, of which Escherichia coli is most common, causing 70%. Klebsiella pneumoniae, Enterobacter species, Proteus species, and Serratia. Non-lactose fermenting colonies mainly are being seen with Pseudomonas aeruginosa and Acinetobacter. Rarely, sometimes gram-positive bacilli like Mycobacterium tuberculosis can also cause. And fungal agents like Candida albicans, parasitic Schistosomal hematobium, Trichomonas vaginalis, and Dactyphilus rhinale viruses, DK virus, adenovirus can cause, and adenovirus, especially types 11 and 21, can cause urinary tract infection, whereas 40 and 41 causes diarrhea. Types 40 and 41 cause diarrhea, whereas the types 11 and 21 cause urinary tract infections. Apart from these, gram-positive cocci are also there, like enterococci, Staphylococcus saprophyticus, Staphylococcus aureus, Staphylococcus epidermidis, and Staphylococcus agalactiae, of which a lower count of even Staphylococcus aureus can also be determined as a significant bacteria. I just want to give a brief note on pathogenesis too before we understand about the diagnosis. Why it is because, so if we understand this, we'll exactly know how and we need to go for the diagnosis. So there are one of the route through which the pathogenesis can occur is ascending route. You can just check the picture here. So there's urethra, bladder, ureter, and also the kidneys, where you see the lower urinary tract infections mainly involved in the bladder and urethra, whereas the upper urinary tract infections, the ureter and also the kidney. So if you see mainly the ascending route of infection that is occurring, so ascending is from urethra towards the bladder, the bacteria enter and then invade and then cause the disease, which is the most commonest route. And enteric endogenous bacteria, that means bacteria that are predominantly seen as endogenous bacteria in the intestine, like Escherichia coli and other gram-negative bacteria, and also enterococci. So these are try to enter the urethra, facilitated by either by sexual intercourse or by either any instrumentation or an unhygienic methods that are being present. So these can enter through the urethra and ascend towards the bladder and cause the urinary tract infection. And once they enter, they initially colonize, and if they form a colonization, adhesion mainly to the urethral epithelium with the help of fimbriae and mannose-resistant fimbriae, especially Escherichia coli attaches to this uroepithelium. And later, extension occurs, pathogen ascends through urethra upwards towards the bladder and cause inflammation of the bladder, which you call it as cystitis. Bacterial toxins may facilitate the ascension by inhibiting peristalsis. Further accession sometimes can occur, which can enter the ureter, where you see it as a vesico-ureteric reflex, and even enter the kidney, causing pyelonephritis. And this and all are ascending route, where you see an acute, if this occurs, there will be an acute tubular injury, tubular obstruction and damage also can lead to this kind of infection to occur. The second one is a descending route, where you see mainly infection being there in the somewhere, and then it enters into the blood causing bacteremia, and through the blood it enters the kidneys mainly. That is the hematogenous spread, hematogenous seedling of the pathogens can enter the kidneys. 5% of the urinary tract infections are mainly due to descending route. Organisms commonly associated with this descending kind of infection are Staphylococcus aureus, Salmonella, sometimes rarely, Mycobacterium tuberculosis, Leptospira, and Candida. So initially, the patient might be having some other infection where the cause might be, it might lead to bacteremia, and this bacteremia later through hematogenous spread enters the kidneys and also the urinary tract, leading to urinary tract infections, which you call it as a descending route of infection. Apart from ascending and descending routes, even the host has certain factors to defend, that is the host defense mechanisms, where you see some factors like urinary factors and also mucosal immunity factors can also play a role. Acidic urine inhibits the pathogens, and high urinary osmolality inhibits the pathogens. So these are the urinary factors. If the urine is acidic in nature, automatically because of the more acidity in nature, the bacteria die there, and the pathogens will not multiply much there. And if there is a high osmolality also, it inhibits the multiplication of the pathogens. And urinary inhibition of bacterial adherence also can lead to a decrease in the quantity of the bacteria to multiply. Mechanical flushing by urine flow. So a fast flow of the urine can also throw the bacteria out, flush out the bacteria, and the pili or fimbriae might not help out to attach to the urinary epithelium. And mucosal immunity, uroepithelial secretions of cytokines. So these are all various other factors where you see cytokines play a role in mucosal immunity induced by bacterial lipopolysaccharide. And mucosal immunoglobulins prevent attachment of the pathogens to uroepithelium. There's a protein called as uromodulin, called as TAM phosphoprotein, a glycoprotein secreted by epithelial cells of kidney. It serves as anti-adherence factors binding to type 1 fimbriae of the toxic excretion. In men, especially, if you see zinc in prostatic secretions is bactericidal, and also a long urethra in case of men can lead to very rare cause of causing urinary tract infections. So these are the host factors or host defense mechanisms where both mucosa play a role in its immunity, and also the urine, the outflow of urine or the urine also plays a role in defense mechanisms. I'm not going much. These are all are very predominantly known, the manifestations of urinary tract infections. You can see it as an asymptomatic bacteriuria, inflammation of the bladder leading to cystitis, inflammation of urethra leading to urethritis and acute urethral syndrome. Upper urinary tract infections mainly involving the kidney, cortex of the kidney leading to pyelonephritis, urethritis, perinephric abscess, renal abscess and renal tuberculosis. And lastly, some complications might occur because of continuous urinary tract infections which lead to post-streptococcal glomerulonephritis. Asymptomatic bacteriuria means isolation of specified quantitative count of bacteria in appropriately collected urine specimen obtained from a person without symptoms of urinary tract infection. It's most commonly seen in case of females, and incidence increases with the age. So there will be no symptoms in the patient, but the specified quantitative count of the bacteria will be in an appropriately collected urine specimen, will be without any symptoms in the urinary tract. So clinically, this is significant in case of pregnant women, even though it is asymptomatic without any symptoms. So this has to be considered as significant in case of pregnant women, people undergoing prostatic surgery, or any urological procedures where bleeding is being anticipated. Routine screening and treatment of asymptomatic urinary tract infection is being highly recommended. And clinically, it is not significant in non-pregnant women, premenopausal women, old age, even in a catheterized patient or a patient with spinal injury. Neither screening nor treatment of asymptomatic urinary tract infections. Clinically, it is not significant, it is not required. Whereas inflammation of the bladder, which you call it as cystitis, there will be dysuria, difficulty in passing urine, frequency of urination, urgency and suprapubic tenderness, all these will be there. Urine becomes cloudy with bad odor, and in some cases, sometimes you see hematuria, blood in the urine also. No associated systemic manifestations will be seen. Whereas acute urethral syndrome, seen in young sexually active females, classical symptoms of lower urinary tract infections, as described as that is similar to that of cystitis. Bacterial counts will be very low, where you see a 10 to the power of 2 to 10 to the power of 5 colony forming units per ml. There will be pus cells that are being seen in the urine. Pyuria is being seen. Agents, mostly due to usual agents of urinary tract, like few cases caused by gonococci, chlamydia, herpes simplex. So you see the what you call genitourinary kind of infections, especially leading to the gonococcal infections and also chlamydia and herpes. So finally, if you look into what are all the various things that you look into laboratory diagnosis of urinary tract infections. Initially, what you need to do is a sample collection has to be done. The sample that has to be collected is definitely urine, and urine is collected in a wide-mouthed screw-capped sterile container. And important thing to remember, and you need to tell the patient, to give the instructions to the patient to collect the urine in a proper way, where you need to ask the patient to collect a clean catch midstream urine. That means the first urine has to be voided out. Before that, the patient has to clean the urethral meatus or the glans penis. and then the first urine has to be voided out and has to collect the midstream urine as it has a clean catch urine. So most common specimen for urinary tract infections collected after properly cleaning the urethral meatus or glands. And apart from the clean catch midstream urine, you can also collect suprapubic aspiration from the bladder. Actually, this is the most ideal specimen recommended for patients in coma and also in patients. Those who cannot give by themselves the midstream urine, like patients in coma or otherwise infants. And if at all, you commonly see people who are catheterized in the hospitals. So how do you collect the patient samples, urine samples in a catheterized patient? Urine is being aspirated from the catheter tube after clamping distally and disinfecting, but never collected from the urine bag. So this is an important point to note. So most of them generally, due to lack of awareness, they collect the sample sometimes in the urine bag as the patient is not passing the urine properly when a catheter is being placed. And that is very wrong. And you need to collect it from the catheter tube after clamping it distally and disinfecting it. I'll just show you the picture how to collect it. So this is the urine container, a sterile container that has to be used with the proper labeling. And you can see this picture clearly shows you how to collect and from where you need to collect, not from the bag. But if the patient is having a catheter and a catheterized patient, there will be a sample port. The blue one that you are seeing is nothing but a sampling port, and we found on the tubing of the catheter draining bag. Urine should only be obtained from this point. So what you need to do is, this is the catheter which is going into the urethra of the patient, and distal to that part where you need to clamp it initially so that the urine will not pass into the bag, and now clean the port with what you call an alcohol impregnated swab, and then dry it. Once you dry it, then put the syringe into that port, and then withdraw the urine, and then once you draw appropriate amount of the urine, then put it into appropriate container, label it properly, and then remove the clamp so that the rest of the urine is being passed. So this is the way that you need to collect from the catheter, and that is more important. Why? Because unnecessarily we get contaminants or otherwise the other bacteria to other than the expected bacteria to get from the urine sample. So once you collect the sample, the next thing what you need to do is transportation of the sample. So especially the urine samples has to be processed very much immediately once you send the sample, and the expected delay for more than 1 to 2 hours. If you are expecting, so it should be not less than 2 hours. Once the sample is being collected, it has to reach the laboratory within 2 hours. If it is taking more time than 2 hours, either you need to refrigerate the sample, or otherwise you need to store it by adding boric acid. And if you add boric acid, store it, for maximum you can store it about 24 hours, not more than that. Otherwise, the sample is of waste. And once a sample is being sent to the laboratory, so the initial thing that has to be done in the laboratory is a direct examination of the sample, where you go for a wet mount examination to demonstrate the pus cells in the urine. And more than 8 pus cells per cubic mm is considered as pyuria, which is a significant kind of thing. Apart from that, you can also go for leukocyte esterase test, which is a rapid and cheaper method. Detects leukocyte esterases secreted by the pus cells present in the urine. Also, you can go for nitrate reduction test, which you call it as a grease test. Nitrate reduction test is done to detect nitrate reducing bacteria like Escherichia coli, which gives it as positive. So these are generally done as a direct examination test. Apart from that, gram stain is also done, but gram stain is not recommended for a routine. It's not a reliable indicator. Whenever you suspect it as an upper urinary tract infection, then it's always better you can go for gram stain. And if you are suspecting a Mycobacterium tuberculosis infection, it's better to go for AFP staining. A centrifuge sample has to be taken for AFP staining. And apart from direct examination, you need to go for culturing the urine sample. Urine sample is inoculated into three different media. One is a clad medium, which is otherwise called a cysteine lactose electrolyte deficient agar, and also McConkey agar and blood agar. So in these three media, the sample will be inoculated. And once the sample is being inoculated in the clad agar, if you see the lactose fermenting or an acid forming colonies, where you see them as yellow colored colonies, where a non-lactose fermenting colonies kind of things, where no acid is being formed, where you see them as a pale colored colonies. So this is the normal control plate, and these are Escherichia coli and non-Escherichia, so multiple organisms that are being seen in case of Cletbury. You see on McConkey will show a lactose fermenting colony which are pink in color, whereas a non-lactose fermenting colony which are pale. So you can easily differentiate them as it is a differential media where you can differentiate between a lactose fermenting and non-lactose fermenting colonies. So there is a concept called as a CAS concept where you determine them as a significant bacteriuria in cultures. CAS concept of significant bacteriuria based upon what you call based upon the number of colonies that are being seen, though the normal urine is being sterile, may get contaminated during voiding with normal urethral flow. Bacterial count is contaminated. Bacterial count in case of contaminated urine would be lower than that caused by an infection. So you need to count them. So if you see, there will be multiple bacteria that are being growing. So you need to know the counts of the bacteria where by which you can determine whether it is infective, that organism is infective or a pathogen, or otherwise it is a contaminant. So the CAS concept says the significant bacteriuria as a count of greater than or equal to 10 to the power of 5 colony forming units per ml of urine considered as significant indicates an infection, whereas counts between 10 to the power of 4 to 10 to the power of 5 colony forming units per ml indicate a doubtful significance should be clinically again correlated. And if the counts are less than 10 to the power of 4 colony forming units per ml due to presence of commensal bacteria, these counts might be there and it's of no significance. If you see low counts, there are certain conditions where these are significant, where a patient on antibiotic or on diuretic treatment should be considered. So if the patient is on an antibiotic, that's why in the prescription, definitely we require what are all the antibiotics that are being used for the patient so that we can consider the counts based upon the counts, whether it is significant bacteriuria or non-significant bacteriuria. And in the same way, whether the patient is on any diuretic treatment or not. Infection with gram-positive organisms like Staphylococcus aureus. So a minimum number of colonies of Staphylococcus aureus is considered as significant. Pyelonephritis and acute erythral syndrome is considered as minimum number of colonies are being considered as significant. Sample taken by suprapubic aspiration, again definitely it is being considered as significant. In catheterized patients, if the patient is symptomatic, then the count of greater than or equal to 10 to the power of 3 colony forming units is also being considered as significant. There are other methods where you can detect by culture. There is a quantitative culture method and a colony appearance. So it is done to count the number of colonies. So colony is nothing but a single clone of bacterium that is growing. So you determine it by either a semi-quantitative method or a quantitative method, which you do it by a standard loop technique or otherwise a pore plate method. Colony appearance, lactose fermenting and non-lactose fermenting colonies. I'll just tabulate and then show you various identification points also here. So if it is Escherichia coli, McConkey or Clet, you see lactose fermenting colonies, yellow and also pink colored colonies, whereas blood agar, they show gray moist colonies, and these are on smear gram-negative bacilli which are motile, and there are various biochemical reactions that you do. Indole, citrate, urease, and triple sugar iron test. So they show various characteristic features. Based upon these, we generally determine or detect the determine the genus and species name. Klebsiella pneumonia. So we do, apart from culture, we need to do the staining again and then check for the motility by doing a hanging drop method. And also we do various biochemical reactions, which are all conventional methods by which you do indole, citrate, urease, and triple sugar iron, and determine and finalize the genus and species name. So Escherichia coli, Klebsiella pneumoniae, so they have different characters. You can see this, both are gram-negative, but these are non-motile. Both are lactose fermenting colonies, but this is flat colony, this is a mucoid colony. If you see Proteus, you see a late lactose or non-lactose fermenting colonies, and swarming growth is being seen on red agar. So all the properties change depending upon the organism, so that we can try to identify which organism it is. So all these again the same. These are some of the gram-positive organisms where you see Enterococcus, Staphylococcus aureus, and Staphylococcus saprophyticus. These are all conventional methods, whereas you have automated methods too, by which you can try to determine, especially for urine culture. So you grow them. Once you grow the organisms, so put the organisms into an automated system called as Vitec2 compact system, Vitec method, where you can determine or identify both identification of the organism with various biochemical reactions which are being done, and also antibiotic susceptibility testing with minimum inhibitory concentration values. You can also get the minimum inhibitory concentration values also. There is another instrument called as MALDI-TOF, which is called as a matrix-assisted laser desorption ionization time of flight method, where this helps out to identify. This is mainly based on mass spectrometry, which helps you to anything can be taken. Either a sample directly can be taken, or the organism can be directly taken, or otherwise the clinical specimens that can be taken, either whatever sample that you take. So through the mass spectrophotometric method, it identifies the organism by giving genus and species name. It can also do the antibiotic susceptibility testing. It can also further serotype which kind of serotyping it is, and also even try to treat the biomarkers also. So this is the latest automated method, and this costs a lot. Antibiotic susceptibility testing, as I said, can be done either conventionally by a disk diffusion method called as through Miller-Hunter-Nagar, by Kirby-Bar method, and also a minimum inhibitory concentration method by MIC method, where you do it by a Vitec2 compact automated system. So there is another, lastly, I just wanted to conclude with telling you about an antibody-coated bacteria test, where you can do it especially to differentiate between upper urinary tract infection and lower urinary tract infection, but this is very rarely done. In upper urinary tract infection, route of spread is hematogenous. So antibody-coated bacteria are being taken. A bacteria-coated will come out with the specific antibodies which are being found in urine, and through kidneys, through ureter, bladder, and then they come out. Whereas a lower urinary tract infection, they don't have any specific antibodies. The urine will not have, the bacteria that are being found in that particular urine will not have any antibodies. These are all the various diagnostic methods by which you can try to detect the urinary tract infections. I think I have done it in time. Thank you. Thank you very much. Thank you, sir. Sir, you are on mute, sir. Please unmute, sir.
Thank you, Dr. Kishore.
Sir.
Now the session is open for any questions from the audience. Whoever is having any doubt can clarify their doubts. Is there anybody? So no questions asked, Dr. Kishore. Probably we can conclude the session. And I thank you very much, Dr. Kishore, for the
Thank you.
very good and an informative lecture.
Thank you very
Thank
much.
you.
So thank you very much for the entire VDC for giving me this opportunity.